Good day and welcome to part 5 of the orthopedics module. I'm Dr. JB Alonto. So, as an outline of our orthopedics module, we discussed the review of the musculoskeletal system, orthopedic history and physical examination, and general orthopedics and parts of orthopedic trauma we already discussed. So, for this lecture, we'll be continuing discussion on trauma, particularly orthopedic trauma by regions. So this is your pretest. So today we'll be discussing orthopedic trauma by region. So I divided it into your upper extremity and your lower extremity. So it will be quite a lot. So be prepared to pause and sum up parts of the video. So clavicle fractures basically occurs on a fall on a shoulder. And since the clavicle is subcutaneous, the fracture is often evident on inspection. It is one of the most common fractures in orthopedics and majority occur in the middle third. Uh, most clavicle fractures can be treated non-operatively, either with a sling, early range of motion, and gradual return to normal activities. So, we usually do surgery if the skin is tenting, the clavicle is displaced and shortened. Like in this case, there's some degree of shortening, some comminution. So, we did some surgery for this patient. Distal clavicle fractures is less common but may occur if there's a crack of clavicular ligament rupture. So this is particularly troublesome and they're really candidates for surgery. Also, what we look at is the displacement in the acromic clavicular joint, and this would need some surgical repair, especially in athletes and manual workers. Scapula fractures basically they signify high energy trauma because the scapula is covered in soft tissue, particularly your scapular musculatures. They would protect your scapula from uh, trauma. So if you see a scapular fracture, it indicates a high energy trauma. So 80% they have associated injuries, most commonly with the head, the ribs, and the lungs. And like in this picture, you have a CT with 3D reconstruction to view the which fracture is, which part of the scapula has been involved. Treatment basically is non-operative, but except for glenoid involvement, as in this case, where you see a involvement of the glenoid fossa. So this would predispose to a joint subluxation. So we did some surgery, screw fixation. There are some other options like plate and screws as well. Shoulder dislocations are basically the most commonly dislocated large joint, and mostly it is dislocated anteriorly. So you have your what we call a bank cartesian and a heel sax lesion. Bank cartesian would particularly pertain to the injury to the anterior inferior glenoid glabrum or your bank cartesian, while the heel sax would pertain to the fractures of the humeral head. You have to check for rotator cuff tears or axillary nerve damage. Uh, the younger the patient, there's a much higher recurrence, and rotator cuffs in the elderly you have to watch out for. So the X-ray views you have to request. You have your axillary view and scapular Y views. So this is usually this is the surgical repair where you do a bank cart repair arthroscopically, and this particular is type of reduction. So you sedate the patient either GA or IV sedation, and this is what we term as the Hippocratic method of shoulder reduction. So this is quite crude. It's done by just one person. You can actually do this in the emergency room, but don't do it in front of other patients. Proximal humerus fractures, basically, they occur in high energy trauma in young patients, and in older patients, they occur following a fall into the shoulder. So you have your NEARS classification. Basically, you have your humeral head, your greater tuberosities, your lesser tuberosity, and the humeral shaft. So NEAR basically subdivided it into 4 parts. So this dictates your treatment. So if there's 1 or 2 parts only that's been separated, it could be treated with sling or early shoulder motion. But if there's a 3-part fracture, then you should consider operation. But it's important that you need to rule out any interarticular fragment. So some would actually request for a CT scan 3D recon. So this is a visualization of the how we see the near and 4-part classification. You have your head, you have your greater tuberosity, you have your lesser tuberosity, and you have this part basically dividing your head and your shaft. So this is a 4-part fracture. So we can treat this by using locking plates, and in some cases where there's severe comminution of the head, we do a joint replacement. This is a hemi arthroplasty. Basically, it's called hemi because we just replace one part of the shoulder, which is the humerus. So humeral shaft fractures, they majority would not need any surgery because it has a high degree of acceptable angulation. You'd be surprised that even for those with 20 degrees anterior angulation and a 30 degrees valgus angulation, they'll still be able to tolerate that much deformity. But it's important to note that there's what we call a Holstein-Lewis fracture. So basically, this Holstein-Lewis fracture is a spiral fracture of the distal 1/3 of the humeral shaft, and in 22% there's a nerve injury. So in this case, we need to do some sort of surgery. So the usual treatment, if there's no nerve injury, we do a functional brace or a cast, or if we need to do some surgery, like in this case, which is comminuted, probably the angle was not good, so we did plate fixation. Distal humerus fractures basically are near the elbow. It's a fall into the elbow or onto an outstretched arm. The force transmitted towards the elbow. The problem with these types of fractures, they're notorious for elbow stiffness. So it depends on the area. So you have your supracondylar fractures, you have your condylar fractures, and you have your interarticular, so involving the joints. So if it's minimally displaced supracondylar fractures, we usually don't uh, treat conservatively, but it's rarely the case. The all the key to treatment is always early mobility. So that's why most distal humerus fractures, I would be more prudent to prescribe a surgical option in order for the patient to quickly mobilize the elbow. So in this case, it's a supracondylar fracture. So it's being fixed with pins. So after we fix the with pins, the patient can particularly move the patient even the next day. It's an example of a bicondylar fracture with some involvement in the articular surface. So we do 2 plates, one on each side, and the goal again for this patient is for early mobility. elbow dislocations basically is a dislocation on an outstretched hand. So I need to do some clarification on your textbook. The terrible triad basically is a dislocation with a coronoid process fracture and a radial head fracture. That's a terrible triad of the elbow. So some would just be simple dislocations, the humerus coming out of your ulna with no fracture. But a terrible triad would look like this. So if you see this, there's some sort of fragment, and you can check. See, it could be from the coming from the radial head or coming from the coronoid process. You have to understand that this would also help in the stability of your elbow. So yeah, fracture in these areas would mean unstable elbow dislocation. Radial head fractures basically is injury to an outstretched hand with the elbow in extension and the forearm in pronation. So the force is transmitted from the wrist to the radial head. So usually, the usual case, you have a minimal displaced fracture. So you ask for patient to be in arm sling, then you early mobilize. And if it's uh, surgery, we usually do it for those displaced fractures or for those that have a block to pronation and supination. And if there's an associated elbow dislocation, since this would be part of your terrible triad. So also important to note, as well as in your textbook, it already mentions some Essex Lopresti fracture, which is basically a fracture of the radial head, but with a transmission to the interosseous membrane. So that's important why you have to x-ray the whole forearm. So you can see a radial head fracture. So in essence, the interosseous membrane has ruptured because of the energy transmitted, and you have a distal radio-ulnar joint injury, which in x-rays could be seen as a separation. So we do screws and plates. There are really small plates now available, and 2 millimeter screws. And in some cases, we do radial head replacement. And can't if it's too comminuted, can't afford the radial head replacement, you can do an outright excision. So olecranon fractures, basically they follow a fall directly into a flexed elbow. Because the triceps inserts on the olecranon, triceps would insert here. The pull of the muscle often causes an active extension of the elbow and displacement of the fracture. So this is a classic picture of an olecranon fracture. The fragments being pulled by the triceps, and usually the olecranon fracture should be fixed surgically. You have to consider the triceps pull, and as I said, almost treated operatively. What we do is we use a tension band construct. So you put a wire, then tension wire. So what happens is the pull of the triceps in this construct, it would create a compression facilitating your bone healing. So another option is if it's too small, you can do an excision of the fragment and do a triceps advancement. And it's important to know that with whatever treatment, there's always a chance of elbow stiffness. So our goal is again elbow early mobility. Forearm fractures, basically, it's a fall on an outstretched hand or even direct trauma. So it's important to note the anatomic relationship of the ulna. So the radius, it has a bow and it rotates around the straight ulna for during pronation and supination. And the goal of our treatment is to restore this anatomic relationship. So there's a mid shaft fracture, you have, and the other view you see this bow of the radius. So we have to restore that one. So the location would direct treatment. So isolated radius fractures or isolated ulnar fractures or nightstick fractures, they can be usually treated using cast, splints, or brace. So Montague fracture is a fracture of the proximal third of the ulna with a radial head dislocation. So yeah, it's important to do a lateral x-ray so you can see this radial head dislocation. While a Galeazzi fracture is a fracture of the distal third of the radius with a distal radioulnar joint injury. So these two types are operative. So our options is we use a plate and screws, and in some cases we use pins. So distal radius fractures are the most common orthopedic injury. So treatment basically is based on fracture pattern and stability. Commonly occurs in older patients due to a fall or osteoporosis. So a combination of these factors could lead to distal radius fractures or high energy trauma in the young. So we have eponyms related to distal radius fracture. So this one is what we call the Colles fracture, a dinner fork deformity. So the thumb is here, so the fragment is dorsally displaced. While the reverse one is called the Smith's. So thumb is here, so it's pointing to that direction. The fragment is anterior. You also have your Schaffer's fracture, which is a fracture of the radial styloid. And if it involves the interarticular fragment, we have your Barton's fracture. Basically, a Barton's fracture, it involves an articulating surface. So if you can see here, the joint is intact, while here there's a fracture that crosses to the joint. So scaphoid fractures is the most common fracture of the carpal bone and could be easily missed. And the problem with this, if you miss this, it could lead to non-union and a vascular necrosis of the scaphoid because the scaphoid has a very precarious blood supply. So usually it's a fallen out stretch hand with tenderness and anatomic snuff box. So if we consider scaphoid fractures, we do a scaphoid series or a clenched view, fist view. So clenched fist view, you can see a widening of the scapholunate space. So this could be indicative of a scaphoid fracture. Scaphoid series, we do this in different um, positions. You have your pronated, you have your supinated, you do your lateral and your AP. MRI is also used to detect uh, occult fractures, particularly those complaining of chronic pain in the snuff box. So treatment is by thumb spica or screw fixation. So we discussed the upper extremity fractures. We'll be discussing the lower extremity fractures. So pelvic fractures basically are associated with head, chest, abdominal, and urogenital injuries. It's made up of the sacrum, your two innominate bones held together by strong ligaments. As I said, it's indicative of high energy trauma, and because of the space within your pelvis, the blood loss it could contain even up to 4 liters of blood. Could uh, Patients could present with hemodynamic instability or shock. So the primary concern here was to do immediate resuscitation with fluids and blood, and this is critical in your management. So particularly, they may need to explore to get the bleeders or do a interventional radiologic embolization. The first line of treatment is usually a pelvic binder or a sheath. So this is a pelvic fracture, you see this opening of the symphysis pubis. This is the inlet view. You see some sort of rotation there. The fracture is here. So this is the pelvic binder. This is how you apply if you don't have the commercial type. So you just put a sheet instead of you cover the from the belly button down to the middle of the thigh. Then you bind the cloth. Sometimes we may need to do an external fixation. So pelvic fractures basically has three main fracture patterns. You have your anterior-posterior force causing an open book. So open book because it's like opening the book. There's the spine of the book, then you open from the front. We have a lateral compression. So coming from this side, causing fractures here. And if it's quite severe, you can also fracture this part of the sacrum, the sacroiliac joint, and the vertical shear. So you can see this pelvis shifted upward. So there's vertical shear. So there's already disruption of your posterior sacroiliac ligaments. There's also what we call sacral fractures. So it's important in some cases to do a CT scan to rule this out because this could lead to some nerve injury. Basically, they're difficult to see on X-ray, and the sacral nerves they pass through this. If you can remember your anatomy, and they could result to a high incidence of injuries and your cauda equina syndrome. Treatment is basically for stable and minimally displaced, non-operative or guarded weight bearing. Usually, you don't ask them to sit down. Just lie in bed for around 3 to 4 weeks minimum. So we usually do plate and screw fixation. So this one for combination of a pubic rami fracture with a symphysis pubis separation and sacroiliac joint disruption. So we do a plate and screws, and you insert a cannulated screw to compress the sacroiliac joints. Acetabular fracture, it's important that you rule out the dislocation of the hip because the dislocation, you need to reduce it right away. So acetabular fractures occurs when the femoral head is driven into the acetabulum in the setting of high energy trauma. So again, as I mentioned, you have to rule out dislocation or sciatic nerve injury. So we request for what today views because you would like to visualize the acetabulum in its entirety. So you have your posterior column and the anterior wall, and this is how you do your Jude views. You ask the patient to tilt using a support. The beam is directed this way. Tilt to the other side. There's the affected area, so you point the beam here. So another particular arsenal we use dimension 3D reconstruction. So you can see in its entirety the whole pelvis. So Jude and Liternel, they enumerated 10 fracture patterns, and they said good luck in remembering those patterns. I don't expect at this level that you'll be able to memorize these 10 fracture patterns, but it's good to know that there are 10 fracture patterns, and if ever you want to go into orthopedics, then you need to memorize those 10 fracture patterns. Acetabular fractures are almost always operative because you need to contain the femoral head within the acetabulum. So what we do usually, we use a plate and screws construct. So this one is a combination of probably two incisions, anterior and posterior, where you can see this plate supporting probably the posterior wall, this one the anterior and posterior columns. So hip dislocations, if you compare it with shoulder, the hip dislocation, they occur posteriorly. Usually it's a dashboard injury, most commonly occur posteriorly and less commonly anteriorly, as compared to the shoulder, which shoulder dislocations are mostly anterior and rarely posterior. So there's a risk of nerve injury, so you have to examine the patient for foot drop and numbness at the top of the foot. So same as the shoulder, hip dislocations could just be simple or associated with a fracture of the acetabulum or the femoral head. And this is an emergency because of the risk of the osteonecrosis of the femoral head if the reduction is delayed. So on X-ray, you see this, the head is out of the socket. CT scan to rule out fractures. So this one you already reduced, but you can see the small fragment. So there's a risk of this one coming out. And this one is quite too far, then you have to really fix it back to the joint. So this is a method of doing your hip dislocation reduction. So put a downward pressure on the pelvis. One person does this, and one person would pull the femur going that way. And following the reduction, put traction. So hip fractures. Basically, it's a misnomer. We don't really fracture a joint, right? We fracture a bone. So what we call hip fractures are basically proximal femoral fractures. They often occur in elderly patients after a ground level falls. And the problem with hip fractures, there's an increased risk for many complications because when these patients, they're already elderly with some comorbidities, they won't be able to move around. The mortality in the first year is calculated at 25%. And in one study, they say around 50% will die within the 2 years if surgery is not done. So the early goal is to do an early surgery to prevent complications of prolonged bed rest, like your bed sores, infections, pneumonia. Surgery and implant will depend on fracture location. So the three types of hip fractures or proximal femoral fractures. You have your femoral neck. This one is your intertrochanteric hip fracture between the trochanters of your femur, and you have your subtrochanteric hip fractures. So femoral neck fractures, the main blood supply to the femoral neck and head comes from the deep branch of your medial femoral circumflex, if you can remember your anatomy, which runs around your femoral neck. And when there's a fracture here, it, so the blood supply, it goes from here. And if you have a fracture, essentially you're cutting off the blood supply to this area. So this would result in risk of osteonecrosis. So as I said, it's a fracture within the capsule of the hip joint, and displacement and age of the patient will determine the surgery. So we do either an in situ screw fixation. Minimally displaced, you can do some traction, then do an incision here, then put a cannulated screw. You can do a dynamic hip screw, which is a more stable construct. It's basically one big screw with a side plate and you fix to the proximal femur. Or in some cases where there's already a risk of osteonecrosis, you do a hip replacement. So intertrochanteric hip fractures is a fracture, proximal femur fracture. So as you can see, the fracture line is between the lesser trochanter and the greater trochanter. But because the blood supply is to the neck, usually it's coming here. Usually blood supply going here. So as compared to femoral neck fractures where blood supply is coming here, the fracture line in the intertrochanteric fractures is here. So the risk of osteonecrosis is uncommon, but it can still happen. So the usual treatment is a reduction and internal fixation, and like your sliding hip screw or cephalomedullary nail. Also, in this case, we can still opt for joint replacement. Subtrochanteric hip fractures, particular is the area where it happens. It's a transition zone between it's a cancellous bone and cortical bone. So it's actually a weak spot. So it actually fractures and falls in high energy trauma. So it's also particularly good to note that in some biphosphonate related subtrochanteric fractures. So parang paradoxical, give biphosphonates to increase your bone strength, but in some patients, they have a biphosphonate related subtrochanteric fractures. So your treatment options are your cephalomedullary nail, and this is a fixed angle blade. This is a blade plate. This is a particularly old implant. If one of you are going to be an orthopedic surgeon, I don't think you'll be able to do this procedure. It's quite old implant already. But this one is a newer implant. It's a fixed angle locking plate. So basically, it's a plate and the screws are fixed to the plate. Okay, so we go on to femoral shaft fractures. So basically, it's a high energy trauma. The potential for blood loss is around 1 to 1.5 liters could be lost to this area. And the gold standard for femoral shaft fractures is an intramedullary interlocking nail. Either you put it antegrade or retrograde. So this is the nail you put antegrade, and some would put it retrograde, meaning from the knee going up. In distal femur fractures, it's important to note an articular involvement. And what we usually do, again, is a retrograde nail. This is a retrograde nail coming from the knee going up to fix the fracture. And you have your plate and screws to fix some comminution as well. So knee dislocations. Basically, they're rare but very devastating injury. Usually indicates high trauma. The knee is a very stable joint, but with high energy or with some disruption of the ligamentous support, you could dislocate the knee. The main problem with this is when you see a knee dislocation, most probably the soft tissues injuries are already too massive. Consider your ACL, your PCL, your collaterals, as well as your meniscus and the joint capsules. One particular area of concern when you see this is your popliteal artery, because the popliteal artery would be going here at the back. So at this point, you could expect some sort of disruption. Probably the popliteal artery is already kinked this way, compromising the blood supply to the area. So you have to do your ankle brachial index to check for perfusion. If in some cases they do an angiogram, because the magic hour for this one is 8 hours, because after 8 hours, if you don't reduce the knee dislocation, the high rate of amputation. So we do an MRI if possible to rule out your soft tissue injuries and for surgical planning. Knee dislocation is quite there are a lot of techniques, but basically it's traction, counter traction, then you put it in a knee immobilizer. So MRI, you can see some ligamentous injury as well, some ligament ligament here. So ACL probably has been torn already in this case. So the extensor mechanism is comprised of your quadriceps tendon. Your quadriceps tendon would be here, the patella, and the patellar ligament. So that is your extensor mechanism. So what happens in patellar injury or fractures? Usually it's a fall directly onto the knee or some forcible contraction of the quadriceps. So you have to rule out dislocation. That's why we ask for a skyline view usually to see the relationship of your patella to your femoral condyles. So this is a skyline view. You can actually see the fracture pattern here going that way. So it could dictate what type of fixation you'll be using. So we usually do, if it's a transverse fracture, we do tension band wiring. So if tension band wiring, familiar, we do it in the olecranon. So usually the patella, the fracture is here. So as you can see, this construct is a wire going that way and a figure of 8 wire. So somewhat similar to the one we use for the olecranon because tension band wires use the same principle. The pull of the quadriceps would create a compression across the fracture. So quadriceps and patellar tendon rupture, you also have to consider, and this is a separate repair. And though not necessarily, some would check for an MRI. Tibial plateau fractures. Basically, it's composed of the tibial articular surfaces and the underlying cancellous bone. So as you can see in this X-ray, I have fracture of the articular surface, even extending up to here. This one going down. So this result from axial loads, sustained in falls from height, or high energy trauma. So compression here causing all this fracture, energy going down your tibial plateau. This is also associated with injuries to the meniscus and cartilage. So the classification system we use for the tibia is the Schatzker classification. Basically, it's a class type 1 to 6, with 6 being the worst. So type 1 is a split, type 2 is a split depression, type 4 is a through the medial plateau, then type 6 it's actually both condyles. So non-displaced, basically for type 1 you can have a knee brace, but basically we need to use plates and screws for this construct. So you need to use a plate to compress and screws to keep the fragments in place. Some even use an external fixator as a combination of your screws, and you use this hybrid external fixator, a ring construct with external fixator. So tibial shaft fractures are the most common long bone fractures, and they occur after high energy trauma, direct blows, or severe twisting injuries. So for direct blows, you can create the transverse or comminuted fracture pattern. For spiral patterns, basically it's from a twisting mechanism. So the gold standard for this one is to use an intermedullary nail. So this one is a twisting mechanism, as you can see, the fracture pattern is going that way. So treatment, usually if it's minimally angulated, we put the patient in a cast. But for these types of injuries, we usually use intermediary interlocking nail. Plates and screws we also use, but because of the subcutaneous, the superficial soft tissues in the area of the leg, the hardware prominence is a problem. So if you can see, this is a spiral fracture. So this is a locking screw. So we put a locking screw. It's called a percutaneous locking plate. And because of this, it's important that there's also high occurrence of compartment syndrome in tibial shaft fractures, especially post-operatively. Tibial plafond fractures are typically high-energy injuries that result from the axial compression. So the counterpart of your plafond in the proximal tibia is your tibial plateau, and this one is your plafond or your pilon fractures. So these injuries can cause some significant soft tissue injuries, severely comminuted intra-articular or metaphyseal fragments. So we can ask for a CT scan. Basically, there's delayed treatment due to swelling in the area. Treatment basically is plate and screws. Complications of which is, as I mentioned, soft tissue because of quite superficial area and some hardware complications. The implant could be prominent, and some complications as well is some wound breakage because of blood supply to this area is quite precarious. So several ligaments contribute to the stability of the ankle, particularly your deltoid ligament medially and the syndesmotic ligaments between the tibia and fibula. And you have your anterior talofibular, your posterior talofibular, and calcaneofibular ligaments laterally. So ankle dislocations, it is a complex hinge joint, and as the ligaments already mentioned, so usually it's secondary to a severe twisting injury, and most often than not, there's a fracture involved. Subtalar dislocations are not too common, but could happen medial lateral depending on the location of the foot. The medial dislocation is particularly more common because the medial malleolus is more superficial as compared to lateral dislocation. So treatment is either closed reduction or open reduction. So ankle fractures basically is a result of a twisting injury to the ankle in combination with your ankle dislocations. So it could vary from an isolated malleolar fracture, a bimalleolar fracture, or a trimalleolar fracture. So lateral malleolus fracture, basically there's less than 3 millimeter displacement and no tailor shift could be considered stable. We usually fix this with a plate and screws, so the fracture is around this area. Medial malleolus fracture, if it occurs isolated, could be treated with a cast, but usually if you need to fix it, it's just a screw fixation. So bimalleolar fractures are considered unstable, and the talus will often sublux. So trimalleolar fractures, basically you have a fracture of the lateral and medial malleolus with a posterior malleolar fracture, and usually if it's a small fragment we don't need to fix that. So this one, there's a syndesmotic injury where there's been fixed by plate and screws, and this is what we call a syndesmotic screw. So this one is used to compress this joint. So usually you have a separation of this uh, ligament. So you need what this is the syndesmosis, which actually connects your tibia and fibula. So you need to use this screw there's an injury to this part. There's also what we call a Masonov fracture, which is basically a fracture of the proximal fibula in association with the medial malleolus or rupture of the deltoid ligaments. And this almost always there's a injury to the syndesmosis. So as I mentioned, there's a fracture of the medial malleolus with a fracture of the deltoid ligament. So deltoid ligament and then syndesmotic injury. So as you can see, there's already a gap here. So this could indicate an injury to the syndesmosis. Calcaneal fractures, basically it follows a fall from a height, landing on your feet, and often associated with other injuries like lumbar fractures and even knee tibial plateau fractures. So this has a very high incidence of compartment syndrome of the foot. So on lateral view, this is how we measure the bowler's angle. So this angle as compared to this one. So this is indicative of a calcaneus fracture. So if you can appreciate, the fracture is probably going this way. So pushing this fragment instead of this angle, the angle has been shortened. In bigger hospitals, we can ask for a CT scan. Uh, Treatment basically is like this. You can see the small fragments. Treatment basically, if it's non-displaced, non-articular, you can do casting. And if you opt to do operation, you do screws, a combination of plate and screws. So complications usually are wound complications, because if you can see for yourself, the heel of your foot basically has a lot of fat, so not a lot of soft tissue covering that area, and very high incidence of wound dehiscence. There's also a high incidence of heel pain or arthritis even after surgery. So talus fractures basically happens when there's a forced dorsiflexion on an of the ankle, causing the talar neck to impact on the anterior distal tibia. So what happens is the this the tibia, this the talus, the force is going up, the force dorsiflexion. So the momentum going is this way. So you're forcing this talus to go up a butt against the anterior tibia. Because of this, the precarious blood supply of the talus, it's a high increase. There's a high risk of osteonecrosis of the talus. So in X-ray, we check for the Hawkins sign, which is basically a subchondral lucency that's seen on X-ray after 6 weeks. So Hawkins sign, if you see this, you can see the small line going, if you can appreciate it. It just basically means that there's vascularity involved. So this is a good sign actually. So you look for this after you do your operations. So as you can see in this case, there's already sclerosis of the talar dome. There's no Hawkins sign. That's why they probably opted to do a screw fixation of the talus to prevent your osteonecrosis. So I think this is the last part. There are foot fractures. Basically, the foot provides the bony stability provides your mechanical stability to the arches of the foot. So we have your tarsal bones, your navicular, your cuboid, and the three cuneiforms. They link the hind foot to the metatarsals to to create that arches. The isolated fractures are rare, and And usually when you see foot fractures, we don't usually operate. So we put them in a cast or a splint. But there are two particular type of fractures that are worth mentioning, like your Lisfranc injury, which is basically connects the second metatarsal to the medial cuneiform. So this is an important stabilizer of your midfoot. On lateral X-ray, you can see probably this one because of the Lisfranc injury, the metatarsal could displace. Another type is the base of the fifth metatarsal fracture, or if it happens at the metaphyseal junction, it's called the metaphyseal junction. It's called the Jones fracture. The problem here is, again, like blood flow could be compromised. So if you have a fracture here, blood flow going to this area could be compromised. So there's a high risk of non-union, and because of this could cause some persistent pain. Okay, so how do we treat this? Mm, As I said, foot fractures are basically treated non-operatively with a hard-soled shoe and weight bearing as tolerated. But with the Jones fracture, we do a screw fixation. So we discuss general orthopedics and trauma. Um, this is your post test. Thank you, and I'll see you in the next lecture.